All right. Well, good morning, everyone. Thank you so much for joining us today for day one of our pre-conference talks. We're really happy to have you join us as we gear up for our upcoming conference next week. Today's sessions are meant to give you a quick but meaningful look at the range of work happening across the ChildBright network. You'll hear about everything from early feasibility studies and co-design digital tools to hands-on implementation work, family-partnered research, and thoughts around sustainability. These are short focus talks that really zoom in on not just what has been done, but how teams are trying things out, learning from them, and adapting them in real world settings. We've also built in group Q&As throughout the session. So as you're listening, feel free to note down any questions, thoughts, reflections, or connections to your own work, and we'd love to hear about them. So yeah, as I said, today is day one. We still have 2 more days organized against some other themes. So tomorrow we'll be focusing on youth and family co-design, plus the what we call the well-being ecosystem. And on day three, we are primarily focused on childhood health equity and knowledge mobilization type projects. Um, so in your recent correspondence, you would have received the schedule for today. So as a quick reminder, we are sort of organizing ourselves in groups of presenters, taking a 5-minute break between sets for a group Q&A. So during that period, you can feel free to speak up and ask questions of the presenters, and we're happy to engage you in that way. But before we get started, just a few quick housekeeping items to take note of. Be sure to mute yourself, and ideally, when you aren't speaking, just to switch your video off to help with bandwidth, and to ensure there's limited background noise as the presenters speak. And then, as I mentioned, we do have those Q&A sessions lined up during the session. So feel free to just type your questions in the chat, addressing everyone, or alternatively, you can just raise your hand and we can call on you and you can unmute yourself to ask your question directly to any of the presenters. So before we dive in, just a quick mention as well. So if you have any issues during the session, feel free to reach out either to myself, Corinne, or Elix, who will be on the back end supporting the presenters and hopefully your experience of the session as well. So fingers crossed, we'll have no technical glitches, but if so, we'll just go with it and make it work. So thanks again for being here today and helping us kick off what we hope will be a great start to the conference. With that, I just want to hand it over to Carrie and Monica for our first presentations.
Thanks, Pierre. All right.
Okay. Monica, take it away.
Yeah, so hi everyone. Today we're going to briefly introduce Bright Coaching and then mainly focus on what we've learned about implementation. So what it takes to move an effective program into real world systems. So Bright Coaching is a virtual support program for caregivers of preschool age children who are waiting for developmental assessments or services. And the program is virtual, family-centered, and designed specifically for this wait period. So caregivers receive one-to-one coaching sessions covering important topics like child development, advocacy, system navigation, and caregiver well-being. And so Bright Coaching aims to empower caregivers and help families feel prepared for what comes next. So we're using 3 distinct research phases to help us advance the program. And in phase 1, we focused on effectiveness, so testing Bright Coaching through a multi-site randomized control trial across 4 provinces to understand whether the program improves outcomes for caregivers. And then in phase 2, we shifted our attention to implementation readiness. So looking at feasibility and acceptability of delivering the program in real world settings and identifying early barriers and facilitators to uptake. And now we're in phase 3, which focuses on real world integration. So specifically here, the key question is, how can Bright Coaching be embedded within health and community systems in a way that's practical, scalable, and sustainable over time?
So just to get us started with, does it work? The short answer is yes. But we did want to talk a little bit about how parents and caregivers, because they are the focus of the coaching, we're actually very involved in all stages. So intervention design, which is like sort of the how it's planned, the refinement of the especially the coaching manual and the parent manual. So what they say, the flexible delivery, and outcome selection. So measures that really matter for families. So really taking that into account, because you all have to plan that before you get started. Some things that we did during the actual randomized control trial was troubleshooting issues that coaches were running into. So making changes, supporting them to make changes. The interpretation of findings. So actually looking at the data and giving context, because one of the findings was, one of the questions we had was it time consuming? And the answer to that for many caregivers was yes, it was time consuming. But then the next question was, but was it a good use of your time? And so there was a bit of concern going, wow, is it too long? Is it too time consuming? But then we looked at the, parents were kind of like, well, yeah, but if you look at the good use of time question, parents really felt like it was a good use of time. So it's sort of like trying to balance that and give some context to the data. And then just how would this work in a place that you know? So implementation feasibility. So that's all started. So what we found, this was the results of our phase 1, is 98% gained new knowledge and skills. 98% found the program beneficial. 93% felt they could better support their child. They certainly felt we saw the increased empowerment, competence, and overall satisfaction. And we also saw a clinically significant difference in stress between the two groups, which I will say, this is while parents are on the wait list, just to be clear. So it's a very stressful time to begin with. Also, the pandemic happened in there, and we still saw a clinically different rate of stress. So that actually we were quite surprised and excited about.
And so then we moved on to phase 2, which focused on implementation readiness. And what we did was first aim to refine the intervention for real-world use. So we examined participant feedback and coach reflections to identify core non-negotiable components, which you can see at the bottom of the slide. So things like program flexibility, the one-to-one coaching, and the content were all identified by caregivers and as really important. And after that, we conducted focus groups with caregivers and organizational leaders to validate some program adjustments. And this led to us streamlining the program's content and revising the materials to better reflect the diversity of families and cultural contexts. And we conducted, again, national focus groups with caregivers and organizational leaders. And we applied implementation frameworks to systematically identify barriers and facilitators to the program's uptake. And so we were able to identify these factors at the caregiver, organizational, and system levels. And so, for example, you can see that families valued things like cultural safety and coaches that created a non-judgmental space, but barriers included competing priorities. And for organizations, strong facilitators included things like having clear evidence of benefit and aligning with their organizational missions. But things like staff burnout, limited resources, and limited funding were major constraints for them. And then we also got some preliminary ideas of system level factors. So like the need for clear value for money and clarity on how it fits within existing services.
And I just want to highlight the way Monica sort of did it at different levels in the system is super important if you're diving into barriers and facilitators, making sure you understand where they fit in the system. So there were also changes to what the parent partners were doing. And one of the super fascinating things that I love on our project is that we added participants from the randomized control trial as parent advisors now. So we have people who actually went through the Bright Coaching program and are now advisors on how to implement it, which has been invaluable for us. We were asked about where actually in each province that we would implement this. And then one of the parent advisors joined the research team as a co-primary investigator as well. So we did sort of these, then we kind of went even further down. So we really were looking at a specific organization or a specific provincial health system and how it might fit, or health area and how it might fit in there. And so we did focus groups with managers and decision makers from those organizations, the researcher clinicians, and potential coaches. And the real goal here is to develop like context specific, because every place is going to be so different. So how do we implement in this place? And then we took those barriers and facilitators, that sort of big chart, and we used it to figure out what are some strategies. And here we also need to talk about different layers, so different actors in the system. So we had researchers, we had policymakers, we had community organizations. You can see at the bottom, we did not add more words for lead coaches, coaches, and families, but those are also actors in the system that you might have strategies for. And some of the fascinating ones are, of course, there's a lot of overlap. All three of these funds, grants, and cost sharing are there. But then researchers have very specific things like train the trainer, create tailored messaging, and that messaging needs to go to the policymakers, the community organizations, and all the people down the line. And then, what the community organizations need to do is more like building coalitions, figuring out strategic staffing, those kinds of things. So really understanding what strategies you need for different people at different levels in the system and different actors is really important in your thinking. So then next up, what we're working on sort of right now is really co-creating those implementation plans with the leaders. So what are the actionable roadmaps? And hopefully those roadmaps can help us with other organizations, but each one will be a little bit different. But who's doing it, where it sits in the system, and how it's supported, and how it's evaluated. Back to you, Monica.
Great. Yeah, so now moving forward with phase 3, we want to understand how the program can be sustained and scaled within real-world systems. So given the identified barriers and facilitators from phase 2, a major strategy we aim to implement is the train-the-trainer model that Carrie mentioned. So the goal is to build internal capacity so that organizations aren't dependent on the research team. And so that's one of the things we're going to be implementing. And through a participatory mixed method study, we'll be testing provincial integration and long-term outcomes for families, organizations, and systems. And so this includes looking at things like workforce capacity, organizational fit, and system-level constraints. And so we also have some main takeaways for implementation that we wanted to share with you that we've learned throughout the process. So first off, it's important to start the implementation planning early. So don't leave it until scale up, and you can use theories and frameworks to guide the research. And it's also important to treat adaptation as a structured and intentional process. So adapting a program that you're creating isn't a failure. It's really essential for it to be beneficial. It's also important to consider partnerships and engage different actors early and continuously throughout the process. And lastly, implementation is not a one size fits all. So programs need flexibility so they can respond to local context, culture, and system realities. So our hope is that we can take these lessons to help others bridge the gap from this works to this works here specifically. And so we just want to thank you guys for listening, and we're happy to connect if you have any questions.
All right. Thank you so much, Monica and Carrie. Yeah, so as I mentioned before, so hold on to any questions for now. We will circle back in about 20 minutes. So if you have any questions for Monica and Carrie, we'll be happy to field them at that time. So for now, I just want to welcome Angie, and I believe Brenda's co-presenting with you, to take over the platform and present your work.
Thank you. Let me just grab my slides. I can't see Zoom anymore. So one of the problems with Zoom, are you still able to see my slides okay?
We have your slide deck presenting, yeah.
Okay, perfect. So thank you everybody for joining. My name is Angie Lim, and we're going to be talking to you today about neonatal transitions. I'm a nurse at SickKids, and I'm also a researcher, and I'm the implementation lead for the ADAPT project, which is a project through ChildBright. And I have Brenda here joining me as well.
Good morning, everyone. I'm joining you today as a parent with lived experience in the NICU. I'm here to share what transitions feel like from the perspective of the family and why having the right kind of support during this time matters so deeply.
Thank you. So we're going to start just by kind of situating ourselves and talking about why neonatal transitions matter. So the transitions from the NICU to home is one of the most clinically complex and emotionally intense moments in pediatric care. Families move from highly monitored environment into one where they're suddenly responsible for everything. Communication often becomes fragmented, care coordination shifts across multiple providers, and families are expected to manage this while still processing their traumas.
And there is a real grief and sense of loss in transition. Families have often lived through near-death experiences with their babies, and the NICU team really becomes their anchor. So losing that sense of safety and having someone in your corner can feel like another loss. At the very moment you're expected to feel relieved to be able to go home.
Brenda's just going to share her personal journey and a little bit of her experience with her daughter, Nikki.
So my daughter, Nikki, suffered birth asphyxia and sustained severe global brain damage as a result. The NICU was frightening, but it was also the one place where I felt surrounded by people who understood what was happening. The next fear began when we went home. Leaving that level of intensive support and stepping into the outside world felt like being cut loose. There was no point person, there was no guide, and there was no one who could help me carry our story forward. That sudden disconnection shaped our entire journey, and emergency sometimes filled that gap when it wasn't always the right place to turn. And it also showed me how essential it is for families to have that bridge, someone who can walk with them so they're not left navigating those terrifying early days alone, and someone who can help them build that confidence in believing and trusting their guts. And don't mind the 80s, 90s hair.
Thank you, Brenda. So our work has focused on developing a neonatal transition navigator. So what that is a role designed as a single consistent point of contact for families before and after discharge. The role is intended to bridge hospital and community care and support coordination and education. And it's intentionally designed for families of high risk and medically complex infants.
For families, the navigator was described as a little lifeline back to the NICU, someone who already knew their story, who didn't need them to explain it all again from the beginning, and who understood what it really meant to take their babies home under these circumstances.
So the way we developed this blueprint, so we engaged parents, clinicians, and navigators to gain their perspectives, and we grounded our work in implementation science. We used CFIR to understand the barriers and enablers of such a role, and then ERIC to guide how to implement the change. It was also grounded in ACT, which is acceptance and commitment training, which was intended to support reflective practice and sustainability. Equity and adaptability were embedded from the start and not something that was added later on.
So when you design with families, you don't just get better ideas, you get ownership. Families can tell the difference between systems that were built without lived experience input versus when they're built with them and their insights and experiences at the forefront.
So this is just a very high-level overview of what the neonatal transition navigator role looks like from our kind of study and what we did. So we've got some core and non-negotiable functions, and these are things that should kind of accompany that role across all settings. And these things include things like care coordination, individualized transition planning, family education, empowerment, communication across sectors, reflective supervision, and continuous evaluation. By implementing these elements, we really protect fidelity and ensure families receive consistent relational support.
And every parent needs that space to learn and make mistakes safely before going home. Having that space transfer into navigating that care at home while still being supported helps to build their confidence and agency while continuing to figure things out.
So we also have some adaptable functions. So recognizing that when this role hopefully rolls out across different settings across Canada and maybe more broadly, there's going to be pieces that need some adjustment. So alongside our core functions, we have adaptable components that respond to real world contexts. Families may prefer different communication methods, different levels of follow-up, and different types of support. And by having adaptability, it allows the role to remain equitable while maintaining its core purpose. This also allows for site-specific flexibility in the implementation of the navigator role.
And families found it incredibly reassuring to know there was someone on the other end, someone real, not just the recipient of a letter or a referral, but a real person that could be reached when things didn't feel okay or when questions or concerns arose. And with this, they didn't always need to rely on emergency for that. Sometimes validation and support was all they needed.
And these are just pictures of one of our other parent PWLEs that's involved in our work as well, is Fabiana and her son Gabriel and her family. So we really broke this into 3 phases for implementation in the blueprint. So pre-implementation focuses on readiness and training and role clarity. Implementation includes service delivery, audit and feedback, and reflective supervision. And then finally, sustainment emphasizes integration, evaluation, and scale up. This structure recognizes that transitions require planning and not just good intentions.
And transitions are spaces where identity is built, both for families and for the teams that care for them. So support has to last long enough for that building and readiness to actually happen.
So what we're seeing so far is that intentional transition support can reduce caregiver distress, improve follow-up, and create clearer roles across systems. These are early insights, but they point to what's possible when transitions are designed as part of care and not an afterthought. We know that effective transitions don't happen by chance, and they require intentional roles, relational care, and systems designed around families.
Families don't expect perfect systems, but they do want connected ones. They want systems where they feel seen, validated, remembered, and supported, even after they walk out of the hospital doors. When families are supported through transition, they don't just survive the experience, they begin to feel confident living beyond it.
So as we conclude, we really invite the ChildBright community to adapt this model, partner with families early on, and use implementation science to strengthen equity and continuity across settings.
We thank you for listening and for being part of the work that helps families feel less alone during some of the hardest moments of their lives.
Thank you, Brenda.
Well, thank you so much, Brenda and Angie. All right, next up we have Ibrahim and the Jouet project.
Thank you, Pierre. Can you see my screen?
We're seeing your note slides. There we go. Perfect.
Perfect. Hello, everyone. Thanks for joining us today. My name is Ibrahim. I'm a PhD candidate at McGill University, and I'm so happy to present our project, Co-Design and Evaluation of Jouet. This work has been done with the support of the Jouet App Research Group under supervision of Dr. Keith Chicago. So to start with the introduction, participation in community and leisure is so important for childhood development, and as it improves physical and mental health, social development, and overall well-being and quality of life. Participation is also a key rehabilitation outcome for healthcare providers. However, children and young persons with different disabilities face significant barriers to participation, such as lack of access to information, lack of adaptive and inclusive activities, and lack of coordination across different childhood disability systems. So the Jouet mobile app was developed in 2015 by McGill researchers, Dr. Chicago and Dr. Meinemer, to address the lack of information on adaptive and inclusive leisure activity. And it was done through an integrated knowledge translation, and ultimately it connects children parents, healthcare providers, educators, and community organizations to different leisure activities such as arts, camps, sports in their communities all across Canada. However, the challenge with the mobile app, like any other digital health intervention, is their engagement, is their uptake, providing a high quality user experience for the users, and also engagement and adherence over time. So our previous analysis of the app showed that there is low sustained engagement with the app. And we know that effective engagement with any kind of digital health intervention is crucial to support behavior change, in this case, promoting participation. And we need to provide engaging user-centered design as well as embedding some behavior change techniques. So in order to Jouer app to be successful to promote participation, we need to improve engagement and adherence of Jouer. So one of the potential solutions that we came across was gamification, which is use of game elements in non-game contexts. And it has shown in different domains such as health and education that has the potential to promote motivation, fun, and engagement. However, little was known about gamification for children with disabilities. So knowing this gap motivated us to conduct a review of the academic literature to see what's happening in terms of gamification in mobile app for children with disabilities. And we found many gamification strategies such as reinforcement, fun and playfulness, and goal setting were the most common ones. We found also major gaps that few apps were co-designed with users in collaboration with them, and none of them focused on participation. So knowing these gaps motivated us to co-design and evaluate a new gamified version of the app in collaboration with users and PWLEs to promote engagement and participation. So we did this study through the human-centered co-design approach, which involved different research steps such as pre-design, co-design, evaluation, and post-design. And as you know, the Jouer research team is situated within the amazing Child Bright Patient-Oriented Network, and our PWLEs help us with participating in brainstorming workshop, sharing feedback on gamification strategies, pilot testing the evaluation procedures, consulting on the app design, content, and language, and conducting qualitative data analysis. So in a nutshell, the Jouer research team was involved throughout the design and research process. To highlight a summary of the qualitative results from our interviews and co-design sessions with participants to explore their perspectives and preferences on how gamification, how interactive features can support behavior change, they said that the app needs to support participation goals by providing interactive goal setting, progress tracking, and reflection on experiences. The app should bring fun and motivation, so it can be done through customizing avatar, a reward system, and engaging features in the app. The app should foster connection, so it means that children, parents, and clinicians can collaborate in the app. The app should be inclusive and accessible as we have users with different disabilities, so the features should be transparent, adaptable, and usable. The app should be tailored to the leisure, so it means that content and features should focus on leisure participation. And finally, we need to provide personalized user experience. As we saw, we have different user groups in the app, and they all have individual preferences, goals, and engagement levels. So it is important to provide personalized user experience. So using the results of these, we co-designed a gamified version of the app where users can find leisure activity, their favorite leisure activity in the community, create a personalized leisure plan. They can track their progress and reflect on their experiences. So these features are specifically linked to F-Word framework for childhood development. There is a reward system to sustain engagement and increase their motivation. There is also an avatar system where they can create and customize their avatar, and we specifically co-design disability characteristics in them. And it's worth mentioning that for healthcare providers and educations, we co-design features where they can connect to their clients, can suggest activity to them directly in the app, and monitor their progress. To evaluate the feasibility of this gamified version, we recently finished a mixed method feasibility study. 15 participants completed the 2 month study where they were invited to use the app over 2 months, and 13 of them completed the exit interview where they shared their feedback and their experience in details. So some preliminary quantitative analysis showed that the highest engagement was with the activity planning feature. The mean system usability scale showing how usable the app is was 72.17, surpassing the threshold 68 for good usability. And in overall, participant rated the app 4.3 out of 5, so showing the high acceptability of the gamified Jouet. Also to highlight some qualitative insight, participants love the tracking progress feature because they could monitor their progress, they can reflect on their experience, and overall they found the app fun and motivating. However, they brought different barriers, and the major one was the lack of community program. So in terms of in provinces and in the areas that there is no adaptive and inclusive leisure activities, so participants and users will likely abandon the app because there is no activities they can register and they can use the features of the app. They also brought up amazing suggestions, and one of them was adding an AI chatbot in the Jouet app for personalization and faster searches. To conclude my presentation with some take-home messages, we co-designed a gamified Jouet app to motivate children to participate, and we firsthand witnessed that engaging end users and PWLs is key to creating acceptable and meaningful digital health tools. And for any researchers who want to develop mobile apps or digital health intervention, we need to know that design comes first, meaning that this process is so iterative. So it takes a lot of time, efforts, and communication to get from the starting point, from brainstorming and sketching the early ideas to get to the app that can people use it. And multidisciplinary collaboration among design, development, research, users, and PWLs is essential. And for any healthcare providers joining us today, you can definitely use the Jouet app as a centralized platform for finding leisure activity. You can definitely use it as an evaluation tool to collaborate with your clients and also monitor their progress. I acknowledge the Jouet research team, the amazing team who supported us through the design and research, and also the organization and institution who provided funding and infrastructure. And I'm happy to answer any question. Thank you very much.
Thank you so much, Ibrahim. So with that, that's a nice segue. So this is our first group Q&A segment of the day. So if you have any questions for any of the previous three presenter groups, feel free to either raise your hand or just paste a comment in the chat, and we'll read it out and direct it to the particular presenter. So give you a quick moment, but maybe I can kick things off. And so I guess my first question would be to Bright Coaching. So what lessons from the project can guide equitable scale up of evidence-based programs in real world settings? So what broad lessons, I guess, can be applied to other teams and other IS type work?
Sure, so I'll go ahead and answer that.
Thank you, Monica.
Yeah, so yeah, I think the what's really important is to start planning for the phase of bringing it into a real world system early when you're creating a program. So really, by engaging first, like mapping out all the different actors that have to do with the kind of program that you're doing. So not only the people that will be receiving it, but also anyone that also engages with the people that would be receiving the program in order to get their perspective and make sure that you're filling the gap properly and that it will work within all the existing services already.
I'll just add to that, like part of what we're doing is we have the program, we know it works, but we're working with some people from Jordan's Principle, which is Indigenous based, are interested, but we don't know how it will work. And so it's very much a system of making sure that we're not guiding that process. We have the program, here it is, and then asking them how they imagine it would work for them in their context. So really sort of flipping it on its head. We're not coming in with a program that we expect to be the same. And the answer might be it doesn't work, or it needs to be changed so significantly we would have to retest it. And being open to all of those options is really important when working with specific communities.
Well, thank you, Carrie. Sorry, I lost you there at the end, but hopefully we came through for everyone else. Um, Keiko, you have your hand up.
Thank you. Thank you, everyone. Beautiful presentations. I love the part of responsive systems, and the engagement of patient partners throughout is beautiful, and the results can be seen. My question is actually for the strengthening neonatal transitions presenters. So one challenge we find, or I have found in my research, is to engage with parents in critical times, right? A lot of the PWLEs who engage in many of the projects, they have older children, they are in a phase of life where they have more time or ability to engage. Whereas, like in the prenatal care or just out of transitioning out of neonatal care, it can be a very critical moment, what makes the project extremely relevant. But and also for bread coaching, as I think Carrie mentioned, like they're waiting for service. So it's moments where you are anxious and you have a lot on your plate as a parent, and then adding that, like, oh, now also come contribute to this study might be a lot. So I would love to hear, it can be from any of the presenters really, but specifically, like, what have you found successful in engaging with parents and families in this particular critical moments?
I can jump in first and just say, because people are waiting, they are desperate for anything. So I think ours is a little bit different maybe than the neonatal project. So I'll leave that to them, because ours, people don't have anything. So they're quite excited to have something, is what we found.
I can add to that as well. So from the ADAPT perspective, it isn't something that we're kind of like suggesting should be just kind of like thrown in, but integrated into the care team from the beginning. So having that transition navigator at this outset, so that they're seen as part of the care team, so that helps to develop those relationships early on. In terms of engaging for research, I wasn't part of the original CSINT work. Kayla might be able to speak to that. She's presenting in a little bit because she was more engaged in the acute, asking people and getting participants to enroll in that part of the study. I think it's always that kind of fine balance between meeting people where they're at and giving people the options and providing the services as already mentioned, that people really look for connection and any supports that they can get. So I guess if we're offering ways to support, hopefully that it'll be beneficial to them as well.
If I could add something to that, as a partner with lived experience in this study, I think approaching parents, as you said, Keiko, that are going through that trauma is a little too much for them. It's already too confusing. Everything is already too confusing for them to be able to understand what's going on with their child, let alone partnering on a research study when they're in the midst of this. So I think that's one of the reasons I was asked to become involved, because I have a reflective lens. I'm beyond that and have the experiences of when that wasn't available. And I think certainly moving forward, having the participants in this study might be able to be a pool that the study investigators can pull on, when they're 2, maybe 4 years beyond the experience, and can provide that closer reflection as well.
Fantastic.
Kim,
Thank you.
over to you for a quick comment. Sorry, Kim, over to you.
Oh, sorry for me. I just had a question for the neonatal transition team. I was just wondering, obviously bringing this transition navigator into the system is going to require either like a new hire or like a new role in the system. So how are you guys navigating that? When you're looking at scaling out to other locations?
Yeah, funding is always one of the big challenges everywhere that we look. What we did also try to do is identify how it could fit into existing systems. So not necessarily creating a whole new role, but figuring out who is already doing these roles and maybe carving out a fixed FTE to support that within. The thing that came out as being most important is that it's one consistent person, and that they have that ongoing contact from like the beginning and then they follow them through. So if that's already existing in some domains, which we know that social work, other like neonatal transition clinics already do some of those pieces. So we can provide that guidelines and that guidance on what those core components are. Programs can use that to figure out within their means and their budgets how they can meet those needs. It's just the most important is making sure that they have that ongoing consistent contact.
Excellent. Thank you.
Thank you for the question, Kim. So just a quick thank you again to Carrie, Monica, Angie, Brenda, and Ibrahim. Thank you for getting us kicked off today. I'm happy that stimulated some conversation early on in the, I guess on the West Coast here, early on in the morning. So with that, I'm going to hand things over to Corinne, who will introduce our next cohort of presenters.
Pierre, so up next we have Kayla, and we will get you pinned up there so that we can keep an eye. There you are. Okay, take it away.
Thank you so much. I'll just share my screen. Give me 1 second. I think I just need to change my permissions here. I'm going to be, oh, I might need to rejoin in a second. I don't know if you want to start with the next presenter and then I'll do mine. It's just giving me a permissions thing.
Yep, no problem. We can switch the order. We have Genevieve and Rebecca next on the dock. So we'll just do a little switcheroo and then we'll get Kayla settled in.
Thanks, Corinne. Is Rebecca here? I know she's at work today, so she was just going to join a few minutes ahead. Sorry. I don't know if she's here yet.
I'm going to double check.
Of course, I'm not seeing her in the participant list.
Sorry, I know she said she was available at like 8:45, which is still a couple minutes from now.
All right.
Oh, well, we have Kayla back anyway.
Perfect.
Kayla, when you're all connected, we're going to hand it back to you as one presenter for the next team is going to be joining us soon. There we go. Thank you so much.
No problem. I just had to restart my Zoom. Can everyone see my slides full screen here?
Yep, we can see it.
Okay, perfect. So I'm going to be jumping off of what Angie and Brenda were sharing about the CSENT study. So I'll talk a little bit about the qualitative research element that we did. So this is parent experiences of a nurse navigator in the year post-NICU, and I'm presenting on behalf of our research team here at SickKids. So I'll talk a little bit about the experience of parents of medically high-risk infants who are admitted to the NICU, and then the novel role that we used in our study of a nurse navigator to support parents during that transition home and first year. And then I'll talk about our qualitative findings from the CSENT study. So brief background, infants that are born preterm or with complex medical needs who are admitted to the NICU, neonatal intensive care unit, are oftentimes at risk for medical or developmental sequelae. So they may have medical conditions that need to be managed or frequent hospitalizations. And so parents of these children admitted to the NICU can experience heightened stress, anxiety, and depression. And mental health support for parents is variable across NICUs and is often limited, especially after parents are discharged home. So families and healthcare providers have identified that the tools to address a family's medical and social needs should extend beyond the NICU to include that transition home and the first year of life. To support parents during the transition from NICU to home, we designed the CSENT study. It stands for Coach Coordinated Enhanced Neonatal Transition. And brief overview of the study, it was a randomized control trial. The intervention was nurse navigator led. We ran this at the level 3 NICUs at 7 different hospitals across Canada. We recruited 275 parents, and our primary outcome was parenting stress. But I'm also going to talk about our qualitative interviews that we did with parents to give it a little bit more of that experiential findings that we had. And you can read our protocol paper. It's published in BMJ Open, so there's just a QR code. Our intervention was delivered by a nurse navigator who provided support for 12 months in 3 different ways. The first was through proactive education that targeted typical challenges in caring for high-risk infants' healthcare and developmental needs. The second was through coaching and psychosocial support through in-person sessions during the NICU admission, and then regular check-ins by phone and by email, weekly, and then monthly for that first year. And the nurses were trained in acceptance and commitment therapy. So that was a sort of mindfulness approach that they used in all of their coaching. And then the nurses also provided care coordination by helping parents, empowering them to build relationships and do medical and social problem solving and helping them navigate with their community resources post-discharge. So the qualitative piece of this study, we interviewed a subset of 24 parents who were intervention participants to learn more about their experiences. We did all the interviews at 12 months, and we used thematic analysis to code those interviews and extract key themes. The demographics of our study, just for some context, 94% mothers, approximately half were immigrants, most were married or cohabitating, and most were first-time parents. And average birth weight was quite low, and average gestational age was about 28 weeks for the infants. So our qualitative themes came out in 2 major buckets, the first being parent stressors, emotions, and needs, and the second being elements of the nurse navigator role that helped support those stressors. For the parent experience, parents described that parenting was an emotional roller coaster. Some of them expressed specifically experiencing depression, anxiety, and trauma. Parents felt uncertain about their child's health and future medical issues, and they took on a new medical caregiving role. They expressed that the impact of the NICU was often delayed and they didn't really process it until maybe 12 months later when they were going back to work and things had sort of settled. And so in that line, they expressed that they had a continued need for support long after discharge from the hospital. And this is just a quote here. I'll highlight some pieces of what this parent shared. Just because the baby is out of the hospital doesn't mean the parents are. Parents are still medicalized. I found the study to be extremely helpful, knowing I wasn't the only one who was crazy, because the experience of your child in the hospital is burned into your brain and you can't get away from it. You can only make peace with it, and you need a way to be able to navigate that. So that was just a very powerful quote about this parent's experience in the study and, with the admission in the NICU. The nurse navigator role, we found that parents expressed that they really appreciated that the nurse understood the context of the NICU and what they had experienced, especially that the nurse had met them in person in the NICU, so knew them and their child and their whole story from the beginning. And that helped them provide support later on during the year. They appreciated that the nurses had both medical experience and health system expertise, that they could provide centralized and proactive and continued care, so care that came to them through the form of those phone calls and emails and sessions, and the parents didn't have to worry about who to reach out to or when. The care just came to them. Again, talking about that therapeutic relationship really allowed parents to trust the nurse navigator, open up to them, and ask for emotional support. And parents did describe using mindfulness tools that they learned from the nurse navigator as well to help with their emotional coping. So another quick quote about a parent talking about their relationship with the nurse navigator. This quote, I think, came up in Angie's presentation. "It was my lifeline back to the NICU. They're a nurse and they get me. It's like when you have a person who's in a new country and they don't speak the local language, but then they meet somebody who does speak their native language, and how comforting that is. And I can talk my NICU lingo and people understand me." So essentially, the nature of the role being so flexible and having multiple components allowed parents to engage in the elements that were most relevant to them, whether that was medical questions or getting emotional support. Many elements of the role were aligned with parent expressed needs, which were primarily for emotional support. And we did see that there was a long-lasting impact of the NICU. So it lasts long after hospitalization, and support may be needed beyond those 12 months that we looked at for our study. Thank you.
Thank you so much, Kayla. So we do have our two next presenters in the queue. We have Geneviève and Rebecca. Take it away.
Thanks, Corinne. I'll share my screen here.
Great. Ready to go, Geneviève?
All set on my end.
Amazing. So, hi everyone, and thank you for being here today. My name is Rebecca Pierce. I am a parent partner with the Parent Voices Project, and I've been involved throughout its development, from early discussions about what felt missing in follow-up care to reviewing measures, interpreting findings, and thinking through implementation. So I'm joined today co-presenting with the project's research coordinator, Geneviève Southerns. Parent Voices started because many of us, parents, clinicians, and researchers, noticed the same gap. Follow-up care for children born preterm or with medical complexity is often framed entirely around neurodevelopmental or medical classifications. These outcomes matter, but they don't tell the whole story. So as parents, we live with the day-to-day realities: quality of life, emotional well-being, family stress, participation in daily activities, and how all of this fits together over time. These are the things that shape how children and families are actually doing, yet they're not consistently or systematically measured. So Parent Voices is really grounded in two core aims: to measure things that genuinely matter to parents and families, moving beyond a narrow focus on neurodevelopment alone, and to do this in a standardized way across Canada, so parent-reported information is meaningful, comparable, and usable, both clinically and for research.
So in phase one, we focused on building directly on the work of the Parents' Voice Project, which identified a clear disconnect between what parents were saying mattered most and what's typically measured in neonatal follow-up care. From that work, 7 key parent priorities were determined or identified, which you can see on the screen here, such as quality of life, social functioning, and caregiver well-being. Our team then worked to identify validated parent-reported outcome measures, or PROMs for short, which are questionnaires that are completed by parents that could meaningfully capture these priorities while also being realistic to use across the follow-up programs. A quick note on terminology: we now refer to PROMs as Family Important Outcome Measures, or FIOMs, as we quickly learned that within the neonatal community, the shorthand PROM often refers more to ruptured membranes than it does to surveys, so we will refer to it as FIOMs moving forward. We then gathered feedback from both parents and healthcare providers through surveys and semi-structured interviews conducted both in person at conferences as well as virtually on Zoom. In phase 2, that's when we begun implementation, and we're currently working with multiple sites across several provinces that have either implemented the FIOMs or are right in the midst of implementation planning. A central question that is guiding this phase is how we can collect parent-reported information in a way that leads to meaningful conversations and action, not just data collection. So we're partnering with the Canadian Neonatal Follow-Up Network, which is known as CNFUN, and they facilitate collaboration in research, integrated data collection, as well as knowledge translation to improve the quality of care and long-term outcomes of children in their care. And this network has also created a centralized database where a lot of the information from the neonatal follow-up clinics across Canada all get stored, and the FIOM responses will also be inputted here, which is really exciting because that means that they will be available for future use.
So we've learned that the how really matters. Parents and clinicians talked a lot about timing and context. So do you fill out questionnaires in advance or together with clinicians at the clinic? Is there a space to talk about the answers? Does someone explain to you why these questions matter? And if so, who? When parents understand the purpose and can see how their input is used, engagement is much higher and the information becomes far more useful. To ensure that we're keeping parent priorities front of mind during implementation planning, we've developed a parent priority checklist based on interviews that has been shared with sites and is used to guide implementation planning. So one of the biggest learnings for me has been how differently the same tools can be perceived depending on perspective. For example, some participants felt that the PEDS-QL infant scales uses negative language by asking parents to rate problems. We repeatedly heard from providers that this would be a major barrier to implementation for them. However, few parents commented on it, and when asked explicitly, the vast majority felt that the language was appropriate for what it was asking and didn't see it as overly negative. So what may feel uncomfortable or negative to providers can feel honest and necessary to families.
Another critical piece has been around cultural and circumstantial relevance. So at some of our sites, providers importantly raised concerns about culturally skewed questions. For example, some questions reflect specific assumptions about family life that may not be appropriate for their entire patient population, or even like feel appropriate to ask families. Others voiced how just the act of being asked questions is already feels like threatening or intimidating. And so adding more questionnaires to an already question-heavy appointment can feel threatening. And so we're really working to ensure that these tools are adapted for unique contexts. And it's a really important reminder that standardization cannot come at the expense of respect or relevance for families. Another piece is that caregiver well-being was identified as one of those 7 key priorities that I shared earlier from the Parents' Voice project, yet it's not captured through the selected FIOMs. So since we've been consistently hearing from parents in particular through earlier phases of the project and the interviews that we conducted, that this is not only wanted, but actually a necessary part of care, we're working really closely with sites to incorporate this either into their intake questions or just at another point throughout the appointment since it's not in the FIOMs. Some sites already do this, which is great, and many others are keen to adopt it. However, we have had some pushback from sites out of fear that if parents aren't doing well, they don't necessarily have the support pathways to be able to direct them. And so we're actively working on developing resources that we can provide those sites to make sure that not knowing where to send someone is not a barrier to asking how they're doing, as we really believe that it's an important part of supporting families in their journey. From an implementation perspective, there's sort of like 3 key things that I feel like keep standing out in our meetings with folks. First of all, the importance of value-aligned teams. We've been so fortunate to work with really great clinicians and parent partners who are passionate about this work and really keen to get things changed for the better. The second thing is really just trying to think about the balance between capacity building, but also feasibility when it comes to how much implementation science theory or practices we're trying to pass on to clinical teams. And then lastly is just allowing flexibility of how the FIOMs are actually administered. So we have a wide range of how people are actually conducting these surveys. And we're really excited to hopefully have a phase 2.5 through Childbright to be able to complete the implementation at the remaining rest of the 24 CN Fund follow-up sites, as well as really shift to more knowledge mobilization, sharing about the project and its impact on follow-up care.
So we believe this project has a clinical impact and also an impact on families and research. So for families, the impact we're aiming for is simple but meaningful, feeling seen and heard in a structured and consistent way. When parents are asked questions that reflect their realities and when those answers matter, it changes the relationship with care teams and it builds trust. Clinically, this work foregrounds family-centered care by prioritizing outcomes that matter most to families, supporting more meaningful conversations and shared decision-making in care. And finally, from a research perspective, standardized collection of these measures across Canada strengthens the CN Fund database, enabling analysis of outcomes that matter most to parents and supporting more tailored care and counseling for families in the NICU. So thank you very much for your time. We're really looking forward to any questions that you may have.
Thank you so much, Kyla, and to Geneviève and Rebecca for those great presentations. So we're now at the point of our second Q&A. I'm going to open the floor to see if people have questions for our 2 presentation teams. Okay. I'm not seeing any raised hands right now. Oh,
I think Pierre.
There we go. Sorry, Pierre, you were at the front of my front of the queue.
Front of the queue. Jump the line. I guess we start a question for Geneviève and Rebecca. So I guess the question I had was, where did my question go? In the project, like what sort of challenges did the team or the project experience when shifting from like a clinical driven metric to family to like ensuring family important outcomes?
I mean, I think one of the biggest one we mentioned was just how this is actually implemented at each site, because then we know that the follow-up visits are already very, very busy. There's a lot that needs to be done. So how do you add on these extra, tack on these extra questionnaires in a way that they're implemented properly and appropriately in a way that's feasible for all of these different sites. I think to me, that's probably one of the biggest challenges.
Okay.
Yeah.
Thank you.
And just to add on to that too, I would say I've been really encouraged by how open sites have been to parent priorities. I know Rebecca mentioned in our presentation about like a parent priority checklist that we've been doing, and I've been leading the actual implementation planning with sites. And I would say like people are very keen to try to adjust implementation around those priorities and such. So it's been, I feel like there hasn't been as much like pushback from a standpoint of like wanting to measure things that are important to families. We're still in like our first batch of 9 sites though, so that might come later because they're the ones that volunteered. But yeah,
Selection
really
bias.
thankful.
But hey, that's encouraging at least. That's wonderful. Sorry, Corinne, back to you.
Thanks, Pierre. Keiko?
Thank you. Thank you again for 2 beautiful presentations. Learning so much. One thing that I'm always thinking of the partners, but in this case, something that caught my attention was the difference in perspective on the measure. So an old, let's say, paradigm between quality of life questionnaire, so the PedsQL is one, is between children and youth and parents. There is always a difference on perspective of what quality of life means, what it looks like. But between caregiver or healthcare providers and parents is one that I haven't seen as frequently. And we think of PWLs as most parents, caregivers, and families, but also knowledge users, let's say, from our studies are the clinicians and practitioners. And it seems that both studies shed some light into this dynamic. I don't know if you want to comment on like how have you engaged with clinicians and healthcare providers in the research projects as partners and how that has impacted as well.
Yeah, go ahead, Rebecca.
Go ahead.
I was just going to say to your point, I think it's been really interesting that sort of like disconnect. In particular, what we're talking about is the PedsQL measure asks like how much of a problem has the following things been for your family in the last month? And most clinicians, their immediate response is like, oh, I can't ask that because it's not strengths-based. And when we talk to parents, a lot of them were saying that it really felt like necessary and honest, and they're like, it is a problem, so I don't really have the same issue with the language. And so I think having like data to support that has been really helpful, and it just sheds the importance of actually engaging with parents and making sure that their voices are part of the conversation. Because I think once we bring that forward to clinicians to say like it's really great to be aware that that could be something that's a challenge, and yet we've also heard that it's probably not going to be a barrier for you. I think that kind of like lets their guard down a little bit, and it's been much more helpful in the conversation to actually be like backed up by many interviews and survey data. From an engaging clinicians perspective too, I would say that for the most part, they've been pretty open to what parents have to say, and definitely having clinicians on our team, as well as like we have a physio, we have an OT, we have a lot of clinician scientists on the Parent Voices team. That's been really helpful to sort of bridge that gap as well, because we have people to kind of speak to various perspectives. I don't know if that answers your question, Keiko, but.
It does. Thank you.
I saw Oksana. Did you have a final comment before we move on with the next presentation group?
No, thank you. I lowered my hand because it partly was addressed in Keiko's question, but that kind of strengths approach language versus problem-based language is something that we as parents grow up with, and there is a very fine balancing act between both approaches and when to use which. So I think both merit understanding and importance. And I could really see how first-time parents in the NICU setting could see everything is a problem. It takes years to understand that we could approach it from the strengths-based approach. So yeah, it's a fascinating area. Thank you.
Thank you.
Thank you so much. Back to you, Pierre.
Thank you, Corinne. And I'm amazed that we are keeping everything on time and on track. So thank you all for keeping everything tight. Yeah, so happy to introduce our next set of presenters. So Roxy will hand over the digital podium to you first. So feel free to share your screen, and we will hand the deck over to you. Perfect. We see your screen.
Okay. I'm just confirming it's just the full slide view.
Yes, you're correct.
Perfect. Thank you. So thanks, everyone. I am a research fellow at SickKids, and I'll be presenting a little bit of a mixture of some of the virtual reality work that we've been doing that combines a couple of ongoing studies. So we're going to talk a little bit about executive function in ADHD. So the population of focus for this work has been children and youth with ADHD, specifically on executive function and how virtual reality might play a role here. So why does executive function matter in ADHD? Executive function difficulties are common and can be quite impairing in youth with ADHD, and they directly affect academic performance, emotion regulation, as well as daily functioning and family life. But access to interventions that focus on executive function is often limited. Specifically, there are long wait lists for interventions. There's low engagement, and then there's limited ecological validity, which really refers to kind of, does it resemble that real world context that it would be implemented in? And so the key problem here is that we have effective theories. There has been research that's been done on executive function. We understand a lot about executive function, but the tools that children are receiving to improve or work on their executive function are often hard to access, boring. So being mindful that fun and enjoyment for kids and youth is something that we need to be focused on. And the interventions themselves are often disconnected from real life. And so then when individuals take part in these interventions, how are those skills or tools learned actually usable in day-to-day life if the interventions themselves aren't implemented in that setting? And so this is where the team thought of virtual reality and the potential advantages here for executive function in children and youth with ADHD. So virtual reality offers three main advantages here that align with some of those gaps that I presented on the previous slide. So it's an immersive and engaging environment, so something that children and youth are quite entertained by. There's greater ecological validity, so the ability here to implement or use virtual reality within real world context, so outside of the lab setting, outside of an intervention setting, and really in their day-to-day life. And it's scalable, allowing for that home-based delivery. And so this creates a major opportunity here where we can focus on potentially executive function interventions within the world of virtual reality. However, the potential here in terms of the clinical promise needs to be paired with real world feasibility and implementation trials to make sure that there actually is that potential. And so the key question driving this work was, can we build a virtual reality executive function intervention that children actually want to use? And is it realistically implementable in the home context? And so that question is what led to the research that I'll be presenting today. So the co-design of VR Focus VR games, as well as an initial pilot feasibility study and ongoing hybrid effectiveness implementation randomized control trial. So VR Focus is the name for the co-designed home-based virtual reality executive function intervention. It's a mouthful. And so it consists of 4 games. The games are titled Mole, Butterfly, Theater, and Lab. And each of the games has been designed to target a specific area of executive function. So for Mole, response inhibition; Butterfly, delay aversion; Theater, visual working memory; and for Lab, monitoring and planning. And so it's this suite of 4 VR games that target those corresponding features. The key features is that the goal is for these to be home-based virtual reality training interventions for executive function. And they were co-designed alongside youth, caregivers, clinicians, and implementation scientists. And I'll speak a little bit about this after, but this was quite an iterative process, making sure that these games actually were kind of usable and entertaining for the children that would be participating, but then also that it's something that is feasible for that home-based environment. So getting feedback from the caregivers, families, as well as the youth themselves was really important in this process. So I'll provide a little bit of a demonstration of one of those virtual reality games, and I hope the audio works, but if it doesn't, then I can kind of explain the video afterwards.
This is the Mole game. You will start the game with a blue hammer and a green hammer in your left and right hand. When you start the game, blue and green blocks will pop out of the table in front of you. The goal of the game is to get points by hitting the green blocks with the green hammer and the blue blocks with the blue hammer. You need to hit the blocks fast before they disappear. But watch out, sometimes the blocks will turn red. If you hit a red block, you will lose points. So remember, hit the green and blue blocks as fast as you can and try not to hit the red blocks. Have fun!
Okay, so that was just a video, one of the instructional videos for one of the virtual reality games, just to get a sense of what they're like.
This is
and so what happened first was that we did a pilot feasibility study. So this was to test whether these games are actually usable, acceptable, and well tolerated before moving to a larger randomized control trial. There were 17 participants here, including both children with ADHD as well as typically developing children, and they participated in a single session lab-based study. So not taking it out into the real world yet, but focused on that lab-based environment. They played all 4 games that I previously mentioned, and we looked at outcomes such as usability, acceptability and enjoyment, instruction clarity, cyber sickness, which is something that's common we looked at with virtual reality, as well as some qualitative feedback. And so just to briefly go over these findings, in general, the instructions were perceived as quite clear across the board for all games. There were minimal documentation of simulation sickness across the 3 different categories there. Enjoyability, they were highly enjoyable across the board. Usability was above the acceptable usability threshold. The games were perceived as quite enjoyable across the board, and difficulty was not reported as extremely hard, so they were manageable. We did look at some group differences there, given that we had typically developing and children with ADHD. The group sizes there were too small to really be able to fully comment on. There were significant differences in ratings for fun on 2 of the games, but this likely reflects the content or design and not their diagnosis. So this is kind of an exploratory analysis and something we can look at further down the road. So we really focused on an iterative co-design process here, making sure to improve instruction clarity, onboarding, as well as engagement and accessibility. And so the outcome here is that the hope is that home-based virtual reality is feasible with supports. And so caregivers specified that their involvement is essential, but that it needs to be low burden. And so we're now moving our focus to an ongoing hybrid type 2 randomized control trial with the goal of recruiting 132 children and youth with ADHD. This will have, the RCT focus of this is that there's an active virtual reality group as well as a virtual reality control group. It's a 5-week intervention with a 12-week follow-up. And the point here is that it's fully remote. So it's home-based delivery of what was deemed as feasible within that initial lab-based study. We're looking at the clinical effectiveness, and so looking at response inhibition, working memory, executive function related impairment, as well as ADHD symptoms, and the implementation outcomes, so acceptability, feasibility, appropriateness, fidelity, and scalability. And importantly, we're able to look at this in both English and French. And so ultimately, the take-home message here is that virtual reality can deliver executive function training that is feasible and engaging. So VR Focus was usable, acceptable, and safe in youth with minimal reporting of cyber sickness, clear instructions, and positive engagement. And now that we have tested its feasibility, we're looking at testing the real-world impact, looking at clinical effectiveness, implementation feasibility, and that scalability for home use. Thank you.
Thank you so much, Roxy. All right, so hopefully you're holding your questions for a few minutes as we hand over the podium to Christina. So Christina, take it away.
Everyone, I'm Christina.
There we go. Perfect. Hi.
You see it? Okay. Hi, I'm Christina. I'm a nursing student at UBC, and my supervisors are Dr. Hal Seiden and Dr. Sharon Hull, and I'm happy to share findings from a study exploring barriers and facilitators to implementing a new clinical pathway in community pediatric practices. This study is part of a child-led project known as the Pain Pathway Project, led by principal investigators Dr. Seiden and Dr. Stephanie Flake. This project focuses on children with severe neurological impairments. These are conditions affecting the central nervous system and often result in motor and/or cognitive impairments that make it so that when a child is experiencing pain, it can become difficult to communicate where they're experiencing pain and what type of pain they're feeling. And this is pain and irritability of unknown origin, which I will just continue referring to as PIUO. And this is incredibly distressing for these kids as well as their families and providers who navigate a lot of exhaustion and uncertainty trying to resolve this pain. So Dr. Seiden and Dr. Oberlander, who have experience caring for PIUO, sought to fill this need for a standardized, efficient, but also thorough approach to managing complex pain. So they created a resource nicknamed the Pain Pathway. This is a clinical pathway, which is a clinical tool or guide that outlines recommended steps to help providers manage PIUO. And the goals of the pathway are to simultaneously alleviate pain via therapies and medications while also investigating the cause of the pain to resolve any underlying disease. But before the pathway is rolled out into practice, the team wanted to test it first. And they did so in a randomized control trial known as Phase 1, where they had clinicians who saw kids with PIUO in hospital test the pain pathway, and overall they endorsed the efficacy of the pathway. But we also want to help providers in community settings address PIUO. However, community practices operate differently from hospitals in many ways. So we moved into a larger project called Phase 2, which is aimed at optimizing implementation of the pathway in the community. So our study is one of many implementation science studies as part of the Phase 2 project. And our question is, what would be roadblocks and what would be helpful to community pediatricians in BC specifically when implementing a new clinical pathway? And we explore this using mixed methods, so a quantitative survey and qualitative exploratory interviews, which I was involved in, and so I will just speak to that component. We used an implementation science tool called the Theoretical Domains Framework, which proposes 14 domains of behavior change. So we designed our set of interview questions to provide opportunities for providers to address each of these domains. And each of them could be framed as a barrier or a facilitator. So a simple example would be with skills. A lack of skills could be a barrier. Ample experience practicing a skill would be a facilitator. Throughout planning for these interviews, we engage with people with lived experience caring for PIUO. So as part of our Phase 2 project team, we recruited pediatricians who had been practicing for some time in the community, some of whom have also contributed to the Phase 1 study, as well as caregivers of children with severe neurological impairments who previously received care guided by the pain pathway in Phase 1. We also have 2 family partners who have lived experience caring for children with health complexity, who have been long-standing members of our research team even beyond this study. Everyone here was involved in all aspects of the research study, so co-writing the study protocol, co-designing the research questions. They were involved in recruitment and data analysis, and we had some regular virtual meetings with everyone here to kind of discuss their experiences with complex pain, their experiences receiving care or delivering care guided by the pain pathway if they're involved in Phase 1. And it really offered some clarity into the key considerations and priorities that we should have when developing and optimizing the pain pathway and its training materials. We transcribed our interviews with pediatricians for qualitative analysis, which is often reported in themes. And these themes capture recurring ideas. And we use a software called NVivo to highlight excerpts of interview responses and sort them into codes, which are essentially working themes. And we use both approaches to coding. One is deductive analysis, where we determine our themes, our codes first, and then we start coding. So our deductive themes were the 14 domains of the theoretical domains framework. So skills, intentions, social influences, all of these. And inductive analysis, on the other hand, involves creating themes based on patterns you're seeing crop up in the interviews, and this was really led by family partners. So for each transcript, we had two team members independently code them for inductive analysis, and then we repeated this process for deductive analysis. And then a third coder reviews their work for discrepancies and brings them to the team for discussion until consensus is reached. We ended up recruiting and interviewing 12 pediatricians from across BC, and many different barriers and facilitators came up. I'll just show you a glimpse of some common ones. And I'll just select a few prominent ones to highlight. So when providers talked about what didn't work well for them when using pathways in the past, sometimes there would be an overwhelming amount of resources out there for a specific clinical issue. And so because of that, it could kind of occlude their knowledge of one specific pathway. And so they would be less likely to learn and use it. Clinicians are grateful for an abundance of resources to help them provide care, but their jobs are so saturated with information that a huge facilitator would be frequently promoting pathway or having easy, diverse, on-demand ways to access the pathway and the associated training materials. So this would be a mix of in-person formats, in-person outreach events, videos, webinars, digital files, things with very low barriers to access and very easy to pull up for use. Another huge barrier was kind of system factors that made it hard for providers to follow a pathway. So this can include limited availability of referrals to other physicians or specialists, long wait lists, difficulty helping families attain diagnostic testing. These could make steps of a pathway inaccessible to families and physicians, especially in certain regions of BC. But a facilitator would be when providers approach their social professional role as the quarterback who provides longitudinal support to families throughout these system challenges and the uncertainty and distress of PIUO. And then another very resonating facilitator was when family providers had a goal of building relationships with families that really honor their lived expertise and empowering families to become collaborators in their child's care, whether that be collaboratively finding ways to best manage pain for their child or exchanging insight on how to monitor for symptoms at home or like how to monitor for them. So if the pathway could facilitate this goal by having maybe another parent component to the pathway, or having the pathway designed to be accessible for both providers and families to use simultaneously, or training providers to really invite families into collaboratively using and following the pathway, that could really support implementation and draw more families and providers to using it. And these two facilitators especially, they really overlapped with some of the things that we saw in our meetings with our parent monitoring board. So that's really good. And there are a lot of other insightful barriers and facilitators. And so we're going to take these findings and develop implementation strategies, which will be run by our clinician and family partners to optimize pathway content and training materials, and to ultimately improve management of PIUO and children with severe neurological impairments to improve their quality of life as well as that of their caregivers. And we also hope that upon dissemination of study findings, that this could help others who are trying to roll out other clinical pathways and add to the conversation about reforms in the healthcare system to better support those with complex care needs as well as the providers that care for them. Yeah, thank you so much.
Thank you so much, Christina. All right, so next up is the Bridging the Gap team. So I'll hand it over to you, Kim.
Okay, great. I'll just show it from my side then.
Perfect, that'll be wonderful.
Okay, let's see. Can everyone see that?
Yeah, so just make sure you did select the share sound option, right? On the share screen. Perfect.
Yeah. Okay, so before I get started, my name is Kim. I'm a postdoctoral postdoctoral fellow at IWK. And I just wanted to start by saying that our team will be sharing an AI-generated video that depicts a fictional conversation between a scientist and a decision maker, one who is developing psychosocial interventions for children with neurodevelopmental disabilities, and the other who would be potentially adopting them into practice. I also want to acknowledge that I'm presenting today from the ancestral and unceded territories of the Mi'kmaq people, and also would like to acknowledge and honor our African Nova Scotian ancestors who have lived here for over 400 years and helped to shape our communities. So without further ado, I'm going to just jump into the video. Let me know if you can all hear it, okay?
We're here to tell you about our study on the experiences of decision makers and scientists in getting psychosocial interventions from research to practice.
Is everything good so far?
Excellent. Yes, thank you. Thank you, Kim.
Our findings are presented as a conversation between a scientist and a decision maker, both working to get psychosocial interventions to the families who need them. This story reflects data from 83 surveys and 37 interviews. Participants were decision makers and scientists. Each was responsible for developing or choosing psychosocial interventions for children with neurodevelopmental disabilities. Decision makers worked in health, education, or social services. Quotes from the interviews are presented in text throughout the video. Our decision maker and scientists have run into each other at a conference. Let's hear what they have to say.
Hi, Alex. It's been a while. How are you?
Hi, Sasha. Nice to see you. Things are busy as always. You know how it is.
Sounds familiar. I've got 3 studies on the go right now, plus teaching and supervising students. I'm trying to connect with organizations interested in adopting our interventions when the research phase ends, but it's hard to find time. It's almost another full-time job.
Yeah, same here. In my world, it's a juggling act to find programs and then get them up and running. A lot of that work happens off the side of my desk. I barely have time to see what's out there, or to figure out whether an intervention would be a good fit for our team.
That's the tricky part. Getting interventions that work in research settings successfully adopted into the real world. When studies show our interventions can improve outcomes, researchers still need to figure out how to get them taken up into practice. Where do we go? Who do we talk to? As a scientist, I expect that strong evidence for an intervention will make organizations eager to adopt it. But I know that's just the beginning. And unfortunately, there is no roadmap. Scientific training doesn't teach us how to scale an intervention much beyond publishing results.
Decision-making in our organization is influenced by many factors beyond evidence. Staffing constraints, funding cycles, leadership priorities, external policies, and political will. Even great interventions can fail to be adopted if timing or fit isn't right. We also need access to enough practical information to help us decide if something is feasible, like cost comparisons, training, staff requirements, impact on workflow, and whether we'll have ongoing support. And there's more. We need programs that fit to our context, the needs of our staff, and of our client families. Getting the chance to speak with scientists helps us see eye to eye to evaluate fit, anticipate extra work, and see what support might be needed for implementation from the very start.
So I'm hearing that evidence is important, but fit and feasibility also matter. You're saying that interventions that are too rigid or aren't a good fit can get rejected, even if the evidence is strong.
Exactly. Our families get supported across health, education, and social services, all with different mandates and funding rules. Those silos make adoption harder. If an intervention doesn't align with mandates, policies, or values, we can't move forward, even if the outcomes look strong.
It really highlights how complex our worlds are. We really need to understand the realities of each other's systems to make things work. That's something our team really focuses on.
Yes, sometimes policies and administrative constraints override everything, like who can deliver a program, who it can serve, and how funds can be used. They can be quite limiting.
Which I guess means if those constraints aren't considered early, the chances of scaling are pretty slim. Engagement is important to us. We often work with families and decision makers in designing interventions, not as much with the frontline workers, those who actually deliver the programs. Even with engagement, it's still challenging to get interventions adopted. Funding is one of our biggest challenges. Who is going to pay after the research is done?
Exactly. And short funding cycles make it worse. They don't always promote long-term sustainability of the programs we adopt.
We have the same problem. Getting research grants is super competitive. I feel like what gets funded always needs to be new and innovative, and there's not as much support for sustaining existing programs. As researchers, we always need to be moving on to the next thing.
Yes, we sometimes suffer from pilotitis. Interventions get piloted for a year or two and then disappear because the funding dries up. Staff, leadership, or government turnover can also be an issue for sustaining programs over time. We need to build sustainable systems from the start, not just introduce pilot after pilot.
Same thing can happen with our connections. Partnerships and connections are really important to us. We can spend years building relationships with organizations or government contacts. Then there's an election or priorities change or your contact leaves. Our hard work disappears and we need to start again. It's a real problem for us.
You know, it's not all bad news. Partnerships with other organizations has been really helpful in getting programs off the ground. And having some support embedded in the organization, someone who can guide adoption and help staff integrate the new intervention, is a game changer. You know, we have a ton of outcome data from our programs. We do a lot of evaluation on outcomes for quality improvement. It would be fantastic to have a researcher help us to further analyze that data. Could be a research opportunity.
We collect information on outcomes for the intervention. That's our specialty. We also try to build in economic analyses into our studies now. That's really important for funders. Training and resource development are also a part of what we do. It all helps to bridge the gap between science and practice. It's been great chatting with you. Seeing things from your perspective helps me think about how I can better design interventions that suit your needs.
At the end of the day, we both want the same thing: interventions that improve well-being, social, emotional, and behavioral functioning for children with neurodevelopmental disabilities and their families.
Looks like the act of bridging our worlds is the actual intervention we need.
Exactly. Collaboration is where the magic happens. We just need a way to make that feasible and sustainable. Let's keep the conversation going.
Thank you to all study participants, our advisory committee, and for generous support from the Child Bright Network and the IWK Foundation. Please visit our website for more information about the study and for contact information.
Thank you so much, Kim. And same for Roxy and Christina. Thank you so much for your excellent presentation. So now we can open it up to another round of Q&A. And so Elise had posted one in the chat from Carolina, and this one's for you, Roxy, on the VR intervention. Is the intervention available for children? What assessment tools did you use to assess the impact of the intervention?
Yeah, so the intervention itself, it's directed at children and youth, specifically looking at ADHD. And so it's something that we're currently, it's still undergoing. And so it's not something that's kind of widely available to all at this point. And the first piece of the work that I presented was looking at kind of the lab-based feasibility and acceptability of it. And now that that piece has been explored and it has been deemed safe and feasible, it's something that we're now testing out the next phase, which is that in-home piece of it. And that's what really looks at kind of, is it effective? And so that's currently one of the outcomes of the actual randomized control trial itself, is we know it's something that is usable, but is it something that actually does improve those executive function outcomes, is the current work that we're exploring.
Thank you, Rox. And maybe a quick follow-up on that question. When you are translating it to everyday home use, like, are there some key considerations between intervention and maybe just typical uptake?
Yeah, one of the big things that has been kind of that ongoing back and forth with the co-creators, so patients as well as caregivers, is the fit and feel of the headsets. And so it's something that kind of within a lab-based setting, there's a coordinator that's there to be able to make sure that it's fitting properly, and discomfort in terms of the tightness of the strap, for example. And so things like that have been kind of ongoing conversations, making sure that that's something that when it is used at home, they're not experiencing that discomfort. And it's also something that they're wanting to use in that home setting versus having within the lab. I know Alex, who's a coordinator for the work, is also here. I don't know if he wants to add anything to that. Put him on the spot, but
I think you addressed the question pretty well.
Thank you. Thank you, Roxy. Thank you, Alex. Ibrahim, you have your hand up.
Yes, thank you all for the presentation. And my question is for Roxy, and I'm curious to know more about the co-design process of the 4 games. And also my second question, how did you make sure while you're co-designing, you're targeting different executive functioning skills?
Yeah, so I wasn't around during the actual co-creation of the games, and so I'll just kind of speak first to it was an iterative process. So working with family engagement team, so patients as well, so children as well as caregivers were involved. Kind of regular meetings to discuss the games, making sure that instructions were understood, making sure that kind of their feedback was incorporated. And that's something that working with the NRC, that feedback was then applied to the games, and then we would bring it back to the patients and families to get their feedback again on that. So really an iterative process there, kind of co-occurring alongside then the pilot study into the RCT. But in terms of the actual game development, I don't know if Alex, you have more to comment on that.
And then I also actually wasn't present during the creation of the games, but more so on the side of continuous improvement, the iterative aspect that Roxy was discussing, like I think is kind of references the question that was posed by Tom P. So working through the games and make sure there was nothing that we included enough like encouraging features to keep people engaged, but also or children engaged, but also kind of eliminating anything that would be too discouraging. Just for example, in the beginning, there's maybe a little short-sighted. There was some during mistakes, when mistakes occurred, there would be like a kind of like a want noise, like which was didn't make children feel good. So we obviously took that out, and then different changes like that. That's okay.
Thank you again, Alex and Roxy. Kim, over to you.
This is just for the VR team as well. I know that the kids and families are going to be the end users, so like the consumers of the product. Who have you identified who would be like the conveyors of it, who would be promoting it and I guess like making it available to families?
Yeah, from my perspective, it's really focused because in terms of the actual RCT itself, looking at kind of those clinical outcomes. And so I think clinicians, implementation scientists, that kind of field of individuals, it could be something that is kind of discussed with patients and caregivers within clinic appointments, assuming it is something that is deemed effective in improving executive function. But then I also think more broadly outside of the clinic setting, I think that there's a lot of individuals that don't make it to the clinic setting, whether it's kind of not yet diagnosed or have symptoms. And so I think that there needs to be kind of some way of knowledge mobilization of this work outside of that clinic care team as well. Because if it does prove to be effective for executive function, that's something that not only individuals with a diagnosis could benefit from, but also individuals with ADHD traits, for example, that aren't yet in the clinic pathway.
Okay, great, thanks.
That's amazing. All right, so with that, I'm going to hand things over to Corinne for our final set of presenters. So thank you so much. It's gone super smooth today. No technical glitches yet.
Let's keep it that way. Thanks, Pierre. So next we have a presentation from Marie-Ève and Bremdeep.
Hey.
Hello.
Thank you. Hello. Can you all see my slides?
We can. Thank you.
Okay, perfect. So I see, so Bramdeep's in the audience. So he's going to be taking questions with me if there's anything that he'd like to share. So I'll get this going. And I think we have other team members. So just to say that I'm presenting this on behalf of the Bright Pathways team. So thank you for attending our presentation. So I'm Maria Bolduc. I was a postdoctoral fellow with the Bright Pathways project and continue to be fully involved. Just want to say that we fully embrace the theme of the conference with the tree. So this is the visual for our presentation. So what we're going to do in the next 10 minutes is that we'll go over the different components, but then you can relate back to it if you'd like, and send us any questions that you may have. So we'll start by talking about like how this research project came about. So the main concern that was raised by families in previous research is that children born with congenital heart disease are at high risk of developmental delays, but there's still no systematic follow-up in Canada as recommended in the international guidelines. So why are we worried about congenital heart disease? Is that it's actually the most common birth defect with an incidence of 1% of all newborns. So there's currently, with people growing up, 250,000 people who lived with CHD in Canada. So on the image on the right, we can see what different types of CHDs would look like. So in the middle, the TGA would be that there's a switch in the arteries so that the blood that's not oxygen, that doesn't have oxygen, would go to where the blood with oxygen should go. And then the last image is where you can see that there's only one side of the heart that's really pumping. So that means that there's mix in the blood that has oxygen and not oxygen. So we've been actually doing very good in fixing some of these conditions now. So most of the children now survive into adulthood, thanks to all of the medical and the surgical advances. But what happened is that as these kids were growing older, we also realized that they were experiencing some challenges, and that the heart condition actually affects the development of the brain, and that starts in utero and affects them in different stages of their life. Obviously, our Canadian landscape is a little bit different. So there's, our public healthcare system, but that's not the only thing. There is definitely, diversity in our population that looks different from the US. But if you see in the image here on the left, there's also just the density of the population. So meaning that, if we want to provide services for everyone, then we may need to do that in a different way. So we also have more and more kids that are identified as being at risk for neurodevelopmental delays because we're identifying more and more factors that can contribute to that. And I'll come back to that later. So in the previous study, what we did is that we looked at all 8 Canadian centers that perform heart surgery for children, and investigated whether they have a neurodevelopmental or systematic neurodevelopmental follow-up program. And in fact, only 4 of them had them. So what that means is that depending where a kid is born, they will get services or not much services, which leads to big inequities. But even when these programs were available, the children that were eligible were only a small subset that were normally based on diagnosis or the presence of additional factors. And at the time of the study, there was only one of these programs that looked at parental mental health. And we also interviewed parents and youth, and they did identify that was a huge problem and brought stress and lack of resources. So to address this, then we used our nominal group process to develop recommendations. So this process is grounded in both evidence and experience. So before we go in depth into the nominal group process, what we're going to do when we lead this group is to go through a few slides that just provide a quick overview of what that literature review looks like. So first, in terms of rate of child development, So we talked a little bit about the mechanisms that underlie why child development would be affected. But what we know is that there's approximately 50% of children with complex CHD, so the more severe malformations that we've seen at the beginning, that would have developmental impairments, and that could affect different spheres of cognition, of psycho-emotional well-being, of language, and of motor skills. Then we also looked at transition to adult care. So what happens when these kids need to go into adult care? Because this is a lifelong condition. So actually what we found in our review, there's 1 out of 4 child now becoming an adult, or and that this goes up to 50% of them by the age of 18. So we're losing a large proportion, and we know that some of the difficulties happen later, and it could be related to having a job or like just being in a relationship. So it's really important that we keep seeing them for a long time. And then so less than 25% of adults with CHD actually see a specialist regularly. And what best practices say is that we should have early planning for that transition to adult care, and then introduction to the adult care team early on. The other aspect that we looked at was parents' mental health. So as we've heard a few times in the previous talk, so parental mental health is really important with kids who have gone through, sometimes life-threatening episodes, open heart surgery in our cases, NICU stays. So the parents that were part of previous research show that there's approximately 25 to 50% who have anxiety, depression, especially around the ICU stay, which is very consistent with what we've heard earlier. And 80% of the parents have symptoms of trauma, and then actually 30% of them meet the criteria for post-traumatic stress disorder. So very important that this is also addressed. And this could eventually have an impact on child development. And the last piece that we looked at is so what did people do around the world with this pathway? So what's recommended in the guidelines, the international or American guidelines, is that all kids should get a full evaluation, which could sometimes be up to an hour and a half of time when the kid reaches 1.5 to 2 years old. So we looked at different examples. This is one way in France that one setting has adapted the guidelines, where the neurologist would make a decision at the time of discharge to either send the kid to one of the different pathway. So this is what's in the guidelines, but depending on their assessment of risk, they could also be seen just at regular intervals for screening questionnaires that are filled out by parents, or reassessed in 3 months because they're unsure, and then reassigned to one of the 2 pathways. So there are different ways that this could be done, and this is what we want to determine in our process. So experience, because in our group, in our consensus group, we will involve different stakeholders because they know what is happening on the ground. So parents, youth, healthcare providers, administrators, and researchers. So after we've presented a much longer version of the literature review that I've just quickly gone over with you, we will ask them to generate recommendations to improve practice with regards to neurodevelopment, parental mental health, and transition to adult care. And then everybody will be generating ideas that we'll put on paper. We'll be discussing all of the different ideas, ranking them on whether they should be adopted or not, and then having a consensus that is made amongst everyone. So that will lead to some recommendations. And sorry, this slide. And then we'll have, and then another project that we have is the risk calculator that I'll just go quickly over, where we're, instead of just basing it on the diagnosis, we're actually looking at all of the different factors that could be affecting child development, and doing a predictor of outcome on 3 scales: cognition, language, and motor.
based on a database of more than 2,500 children from Canadian and US institutions. And we're looking at not only medical factors, but also socioeconomic factors to really be able to identify which kids are more at risk and which kids should get kind of the highest level of follow-up. So with this, we're hoping that both the recommendations and the risk calculator will have health services outcomes, so improve access by having that systematic approach so that the kids are offered services based on their needs and not having to advocate or fight for them, as parents were telling us, which would also lead to greater equity so that services are not based on where a kid is born or the resources that they have, but on their needs. And that ultimately these improvements in healthcare will lead to better child functioning and participation in day-to-day life and improvement in parental mental health. Thank you.
Thank you, Marie-Eve. All right, next up, we have Zeenat and talk about sustainability.
Okay, thank you. I'm just going to share. Okay, we're seeing the slides?
Yes.
Okay, so hello everyone, my name is Zeenat. I am a postdoctoral fellow with the University of Toronto and Women's College Hospital, and I was a grad student with the Child Bright Fellowship as well. And today I'm presenting on behalf of a much larger team on sustainability planning with the Child Bright Network. So this is our much larger team led by Celia Lohr. Also involves a couple postdocs and alum postdocs from Child Bright, including Simone and Catherine, and our patient research partner, Jess Silver. And also we've been having ongoing support and consultations from the Legacy and Sustainability Task Force. So wanted to make sure that we acknowledge the much larger team that was part of this work. And I think I'll just jump right into the project and what it's about. So the rationale for doing this work really came from wanting to know what to continue within the Child Bright Network and how, and what's important for ongoing support for children with brain-based developmental disabilities and their families within the network. So our overall aim was to explore the perspectives of Child Bright members about what aspects of the network's impact and capacity building efforts should be sustained and strategies to sustain them. So to do this, we took an implementation science approach to the work as well as a patient-oriented research approach, which was integrated throughout. We used the program sustainability assessment tool, which I'll go into a little bit more detail in on the next slide. But overall, what we did was we talked to many people across the network. So we did focus groups and interviews with 56 current Child Bright members. 41% of them, which were people with lived and living experience. And these members spanned across 13 of the programs, research projects, and teams across the network. So really got a comprehensive perspective from members across the network and in various projects. And so a little bit more about the program sustainability assessment tool that was used to guide this work. This is an implementation science tool. It's actually a self-assessment tool that, programs and organizations can use to evaluate the sustainability capacity of their program, and actually comes with a bunch of questions to be used as a tool. In this work, we used it as a guiding framework. So we used these 8 domains to kind of see, okay, what was coming up from the interviews and focus groups, and see what was important related to environmental support, for example, or the partnerships that were taking place, for example. So the findings that I'll show relate to this framework in these domains, but we've also got some themes to kind of help with understanding them a little bit better. And within our findings, there was so much data, so I won't be able to present everything today. So it's really just a snapshot of what came out from the project. Okay. So in part of the environmental support domain, one of the main themes that came out was being able to balance the network's vision with funding priorities. So there was a lot of recognition that the path to date has been driven by funder priorities, and that the network really wants to guide their own future direction, but still needing to balance that funder priority. So really that balance there between the network's wants and the funding priorities. As we have a nice quote here from one of our members that says, I want us to pursue the path, really understand where we think we are strong, where we have made very important contributions, and really look to where we want to go, to really take the reins and really allow ourselves to venture out, given the many, many strengths that we have. So really recognizing that ChildBright has many strengths, and there's lots of places that we can go based on those strengths. Another very important theme under financial stability was diversifying funding. And the funding topic came up across many of the interviews and focus groups, and this diversifying funding came across lots of them as well. So really wanting to support research within the network, within and outside of that SPORE patient-oriented research area. Also looking for potential co-funding opportunities with different partners. And also looking at diversifying through a combination of large and smaller pockets of funding for the very different initiatives going on within the network. So we have a quote here that mentions that one of the ways to diversify funding, or one of the ways for increasing that financial stability, is to establish successful co-funding opportunities. So collaborating with another partner, and that this is also one of many different kinds of opportunities that underpin what ChildBright is about. And that in doing so, by developing these co-funding opportunities, we make a much firmer connectivity between the entity and ourselves. So the other partnership and ourselves as a network. So our partnerships domain for the PSAP framework really was very integral to this work. And so here we have an internal and an external example. So being able to increase internal collaborations within the network, but also being able to build on external partnerships. So on the left here, we have more of the internal aspect where we want to have a sustained effort for that collective effort between programs and projects, being able to share knowledge. So the different programs, the implementation science, the EDI, all those different programs, being able to connect with the different research projects across the network, and building that sense of community across members. So here we have a quote that says, thinking about an open invitation, inviting people coming from one program to another and including them together to build that curiosity. And they're saying here that we need some direction for this process. So a little bit more direction in how to make this connection more formal between these programs and projects. On the right here, we talk a little bit more about building on external partnerships. So again, going back to that co-funding opportunity and creating new partnerships across Canada. So a quote here says that we need to have partnerships with different networks, which ChildBright already does do quite well with different networks across Canada. And being able to, that it's important to ensure that our findings can be sustained or meaningfully sustained and used meaningfully. So having those different partnerships to create that knowledge translation external to ChildBright. Within organization and human capacity, we looked at some clear roles, sharing resources, and building expertise. So on the left here, we talk about clear and evolving roles and responsibilities for people so that they know exactly what they're meant to do, defining and supporting an equitable workload, so making sure we have enough people to do the work, and also supporting the process of turnover. And then on the right here, we talk a little bit about building knowledge and skills within and outside of the network. So a little bit of that professional development and providing training opportunities as well, and utilizing members' skills and expertise, particularly within people with lived and living experience. So that came out quite prominent to be able to leverage people with living experiences, skills, and expertise out of just being a patient research partner. And so we have this quote on the right here that talks about implementation science not being an area that everyone has expertise in or that not everyone has experienced. And they say, I think that it's been very collaborative and helpful in the way that the network has supported that implementation science expertise to be able to move the network forward. And another theme here around sharing the network's impact internally and externally related to the communications domain. So wanting to create more accessible spaces and language to share impact, engaging with people with lived experience more explicitly. And this quote here talks about accessibility of information, making sure that everything is inclusive. And on the right here, we have a very important theme that came out related to champions. So needing champions to build collaborations and reach more people. And that this quote is saying that each one of us, all of us members, we are a champion for Childbright, and that can be an excellent tool to disseminate what we've produced. And last theme here is around ongoing focus on the future and the evolving roles of people with lived experience related to strategic planning. And so we talked a lot here around co-leadership models working well for the future, having committed leadership and active sustainability planning within the network, and a desire for more leadership opportunities with people with lived experience. And the quote here talks about having open and transparent discussions around sustainability planning so that we can arrive at a plan, know what's happening, and know how to put things together and a place to actually operationalize what we want to do for the future. So that's the end of the results that I wanted to share today. I also wanted to just do a quick reflection on using the program sustainability assessment tool and its nuances in using this for a research network versus just one program and the complexities of that. And also with this being a patient-oriented research network, the word partnership, there was a lot of layers related to that domain. And we also try to integrate people with lived experience, engagement, and patient-oriented research throughout. And lastly, just wanted to mention that with knowledge mobilization and the impact of the project, we've been sharing our results throughout the project within the network and outside, and we've actually been able to use some of our findings to iteratively improve some of the sustainability activities going on across the network. And I'll wrap up there. Thank you.
Wonderful. Thank you. Thank you, Zeenat. Hopefully we'll get a bunch of questions to you in a minute. And then last but not least, I'm happy to welcome Olga. So Olga, feel free to take over the virtual podium, and we'll be looking forward to hearing about your project.
Thank you. And I believe I shared my slides with the network.
Oh, sure. You want us to share? Sure, let's go
Yes.
grab them, and happy to share them on your behalf. One moment. Maybe if anyone has any burning help if I unmute myself. As I pull those up, if anyone perhaps have any burning questions for either Zeenat or Maria, feel free to raise your hand, and maybe Corinne, if you can just keep an eye on those, and we'll be back in a second.
Sure. Yeah. I know there was something in the chat for previous presentations, but again,
Yes, we
if any-
have. Yes, Corinne, we have a belated question from Oksana about ADHD RTC. So Oksana, maybe you want to come on, or I can read your question. So are the inclusion criteria based on ADHD only, or there might be room to include populations with a different primary diagnosis and ADHD? If anyone has an answer.
So that would be for Roxy and Alex.
Yes.
Yes. Yeah, the current plans are for ADHD only, but we are planning to expand for future studies, and it was considered within the creation of the tools and the planning of the overall arc of the project. But currently it's only ADHD.
Thank you.
All right. We're back in business. All right, Olga, I'll share screen, and you should just feel free to say next, and I can advance the slides as you need.
Thank you. Excellent. Hi, everyone. Hello. Good morning, good afternoon across Canada. A pleasure to be here. Thank you for having me. I'm Olga Arsovska. I'm working as a contractor with MyCern. A little bit about MyCern. MyCern, as most of you likely know, is a federal non-for-profit charitable organization founded in 2006 to build capacity for high-quality applied health research in maternal and pediatric health. It's now linking 21 maternal and child health research organizations based on academic health centers in Canada, and is affiliated with more than 20 practice-based research networks, provides supports to new and emerging teams, and has established strong national and international partnerships. So next slide, please. The goals of the study that I will be talking about was to describe the challenges when conducting a multi-site pediatric patient-oriented research in Canada. So understanding the challenges was primary goal, and we gathered data from two SPORE networks, the ChildBright network, which we looked at the 13 studies, including 4 trials, so 17 in total from phase 1, and the Innovative Pediatric Clinical Trials Network, which had 4 trials. The goal was to develop and learn from these networks and to develop a report in a way evaluation, which will then be disseminated. And ultimately, the goal was to provide recommendations for better supporting pediatric research communities and advocate for challenges and improvements on national as well as local research infrastructures. Next slide, please. We also wanted to describe the challenges of and benefits of doing research with partners with lived and living experience. So really listen to patient and family voices. And ultimately, we are hoping with this research and with the outcomes to drive systemic change. So next slide, please. The study design and outcomes of this study was a prospective mixed method study model. We did have a first phase, which included questionnaires, followed up by semi-structured interviews involving all of the research teams. We did interview also a patient lead who was participating in the IPCT network, and we did have a focus group with the engagement committee from ChildBright to enrich the data of this project. So next slide. For the data collection and analysis process, we have completed all of the data collection and in last year, and this year we're moving with manuscript preparation, and I'm looking forward to sharing that those findings once the manuscript has been completed. So just briefly, for next slide, please, I'll go through the challenges, lessons learned, and proposed solutions. But we did receive quite a bit more feedback, so I'll try to wrap up really quickly. For the top 3 challenges that the research teams have identified, centered around ethics and regulatory delays, recruitment barriers, and resource constraints. I do want to note that a big part played the pandemic, because these studies were undergoing during that time. They had to be stopped, restarted numerous times. So a lot of these challenges were intertwined within these three big buckets, if you will. Also, differences between provinces. So Canada is vast. The first picture that I had from where my CERN research teams or research is based out of, it's across Canada. So that was an additional challenge. And as I did mention, some of the trials did involve pharmaceutical drugs and drug shortages, shipment supplies, staff challenges were also as a result of pandemic challenges. So I just wanted to highlight those as well. Next slide, please. It does overview briefly the mitigation strategies that some of the research teams identified and implemented to run their trials. And one was to improve systemically the processes that they were undergoing, and also some administrative adjustments which provided relief in their studies. There was a lot of relationship-based mitigation strategies that lots of research teams implemented, as well as resource and infrastructure adaptations. Particularly around finances and staffing, as well as contracts was a big domain that was highlighted. Next slide, please. So from the patient lead that we had interviewed from the IPCT network, we did receive these three main challenges that they identified. One was being and feeling as an equal member of the research team, being invited to participate in meetings adequately, and being compensated adequately. It was very valuable to hear from the engagement committee from ChildBrite, which emphasized that these challenges are likely trial specific, and there is a need to explore how many PWLEs contributed to this feedback. So we did have that limitation that we only had one patient lead, so the voices need to definitely be amplified. For this research project, we're also including some research that executive committee and ChildBrite has done in terms of engaging PWLEs on the trial. So I will be including this summary findings into the project as well. So I'd really like to amplify that perspective from that perspective. A regular team building and check-ins can provide, especially during the pandemic, stress could also help to mitigate these challenges. So there was a lot of similar suggestions provided by the executive committee of how to think about these challenges that were brought forth by the patient lead of the IPCT group. Next slide, please. So the top 3 lessons learned from the research team were to implement interdisciplinary collaboration and capacity building, embedding the patient partnership as a core practice, co-learning and empowerment of the study participants, as well as embedded awareness and sensitivity in communities with indigenous research. We were particularly interested in this aspect, and we did have limited feedback on this end. There was only one research project that could speak into this domain, but I do want to highlight that perspective as well. And the third was flexibility and structural, as well as contingency planning. Methodological refinements and research design evolution were also top lessons learned. Next slide. From the patient perspective, patient lead perspective, there was an indication that advocating on each participant's behalf would provide better outcomes. Recognizing the input and capacity of input from the patient lead was also important to them, as well as involving the the participants a little bit more into the project was important. When this feedback was examined, or rather, if the feedback we received from the executive committee, that sometimes it is also important to think about that advocacy can lead to other outcomes, and therefore it would be important that advocacy comes directly from the research team rather than the patients who may not have that capacity or that ability to advocate for themselves. There was a lot of more examples that will be included in the manuscript, but I will move to the next slide with the solutions proposed. So the research teams recommended top 3 things to embed dedicated and skilled roles for continuity and engagement, streamlining systems and infrastructure through harmonization and knowledge resources, as well as building collaborative culture, early feasibility testing, and dedicated consultation networks. And from the patient perspective, the top 3 recommendations, next slide, please, would be to involve the PWLEs from the beginning and all the stages of the research project was very important and highlighted, embedding formal measures for evaluation and meaningful engagement, as well as ongoing capacity building as a systemic priority. So, that was very quick overview. I just wanted to thank everybody who did participate in this project. It was a big undertaking, and thank you to the opportunity to present today, and thank you to my team at Meistern as well. If you have any questions, I'm open.
Thank you, Olga. And yeah, that's a nice segue into our final Q&A for the day. So thank you for sticking it through. I know it's a long day of really great presentations. So yeah, opening it up to everyone. If you have any questions for Olga, Zeenat, or Maria-Eve, feel free to either unmute yourself, raise your hand, or just plug it in the chat, and we'll be happy to field it to them. Maybe I can get us kicked off. Where was my notes I was taking? I guess maybe we'll start with you, Maria-Eve. When it comes to children with CHD, like generally, what kind of gaps exist in the development follow-up for those kids?
Yes. So, well, it varies a lot from one place to another. So, what we're wanting to see, like based on the international guidelines, would be that they have full evaluation at 11 months, 18 months, 3 years old, and then before school age. So we're seeing a wide variation of that, with some centers here actually just doing, the routine follow-up, no questionnaires or any developmental batteries, and then some variations of that. And then the other piece is who's eligible for that. So some of them will be based on, only the child who were born with a single working ventricle will be eligible for the services, and the others then will just go through, the routine follow-up where, if parents bring concerns, then they may get services, but it's also then a matter of, like even what I've seen in our research, is it a first child? Because then, sometimes parents don't know what to expect. So then it's really based on the ability of the parent to advocate for services, which can be very challenging when they're already juggling a lot of information and appointments.
May I just add one simple, maybe just a metric to support what Maria-Eve is saying, that in a recent study, it was found that only 29% of infants who had open heart surgery were assessed for development in toddlerhood. That's quite a low percentage, especially those undergoing open heart surgery, likely attributing to the more complex side of the heart disease. But then, so you have these kids who are only 30% are being followed up, but then you have the other spectrum of CHD kids who may not be as complex, but we really don't know what's happening with them either. So really, we just don't want anyone to fall through the cracks, because providing development care to everyone is not practical and feasible. But how could we do it in a resource sustainable way so that the right CHD child gets the right support at the right time.
Thank you so much, Brahmdeep and Maria. Okay, so I'm not seeing any other questions. We have a few minutes left, and maybe I could keep asking my questions.
Pierre, sorry, there's a question in
sorry.
the chat for me, which I think
Thank you,
is quite
Zeenat.
interesting.
I totally missed that. So feel free to
Okay.
field it.
So the question in the chat is, how are priorities for a renewal grant selected using the implementation approach that was described? So that's an interesting question, and if I don't answer it properly, please ask it again. But I will say that from all the interviews and focus groups, we were able to actually extract some practical strategies. So things that people could do right now to support sustainability. So something as simple as if we have webinars, making sure that they're easily accessible somewhere online for people to access, regardless of funding, for example. And so some of these practical sustainability strategies can be used as some of the priorities for the grants, for example, in terms of how to move things forward based on depending on how much funding there is. And then also we would go based on some of what members felt that were practical things that could be done to kind of enhance engagement throughout the network that might have not been done already. For example, the coffee chats that kind of just started, right? So that's one thing that is something that could be ongoing that's just kind of started. So I hope that answers the question.
I can jump in a little bit as well on this question. So I'm Celia, working on this project with Zeenat as well, and we've also been able to learn as we go and are trying to be able to integrate these results into lots of different places. So thinking about the wider impact, and as Zeenat mentioned, the things we're doing right now, but how are we thinking about some of these priorities within some of these applications and the discussions that are happening across the network, and where can we make sure that we're taking the voices of what we heard and positioning them into the right places is what we're trying to do. Where are those opportunities that we're looking for, and where can we make sure that, like for myself, I try and bring on what I heard from these interviews and integrate that within those ongoing conversations, so more of these views across the network can be part of some of that planning. I think there's always lots of opportunities and ways to be able to engage more people, but some of the things that we're hearing across the board that we're trying to make sure get included in the different versions of what comes next.
Thanks, Celia.
Thank you, Celia and Zeenat. And lastly, maybe I can punt a question over to you, Olga. Based on the work that your group had done, like what generally, and I think you kind of touched on that in the last few slides, but maybe a very top level response would be great. Like what sort of general advice does the work you have done here offer, say, multi-site research networks that sort of aim to maximize impact and the impact and engagement of their work?
That's a great question, and the whole paper that I'm just writing is like I don't think I can provide high level, but some of the things that resonated on top of my head, and it's not on paper, I don't have the manuscript in front of me, but I think to engage with networks was very important in terms of as early on as possible, build those relationships with colleagues. I remember something about ranting in the hallways being a key word or theme, and talking with colleagues, especially through the pandemic challenges, was a big thing. And this follows that relationship-based advice that people had for other researchers who may need to work on multi-center collaborative research, and also engaging the patients as much as possible early on would be, it doesn't seem like perhaps maybe something that we haven't, I've been involved in research for 20 years, clinical research specifically, and I think involving advocates or the people who actually experience those issues early on was very important. So I think highlighting those would be top advices that I personally heard, but I really try hard, and thank you, Celia, for offering that. I jotted some of the ideas. How do you actually match these advices that we heard to the right to the right moments or the right teams? So I think everybody will get advice differently, is what I'm trying to say. So depending on the study, depending on the research team, I think there's snippets there that would advise the team in some capacity that will help them move their projects better.
Well, thank you so much. Look forward to the publication, and yeah, we'll definitely dive into it a bit more. All right. Well, again, thank you all so much for joining us today. I want to thank our slate of presenters for the great work that they showcase here. And yeah, happy that I was able to stimulate some discussion. And I'm hoping it's setting a really great tone for the upcoming conference. If you are joining us, hopefully some of these discussions can continue in person. But just a quick reminder, if you were available or you were interested, we still have 2 days left of a great set of pre-conference talks. So the link you have today will give you access to the other two as well. And I've just popped the schedule in the chat as well, just for you to take a look to see if there are any particular topics that might be of interest to you if you just wanted to pop in and out for a bit. So with that, thank you so much for joining our first day. Look forward to seeing you again, and we will be circulating a recording of these sessions later this week, so feel free to stay tuned for that. And yeah, if any other questions come up, feel free to reach out, and we can certainly try and put you in contact with any of the presenters and have them get back to you. Thank you so much, everyone. Have a wonderful day, and hopefully we'll see you all here back tomorrow.
Thank you. Bye, everyone.